back over to you.
Thank you, Tatiana. I think we'll start with our first panelist, who will be describing her experience with thyroid disease. Kim McNally, would you like to start, please?
Just unmuted. Can you hear me now? Thank you. Okay, thanks, Laz. So my name is Kim McNally. Welcome, everyone. I'm Vice President and Director of Patient Support for the Thyroid Foundation of Canada. So my thyroid journey began in 1981 at the age of 15 when my mother noticed a lump on my collarbone. A referral to Kingston and subsequent biopsy revealed that I had thyroid cancer, and I was told by the attending general surgeon that I would have surgery to remove it. Those early days were a bit of a blur, and without the internet or Google, I turned to our family's Encyclopedia Britannica to see what a thyroid was because I'd never heard of one before. My surgery was very invasive. It included the removal of my thyroid, parathyroid, and a number of lymph nodes. It left me with palsy of the tongue and a paralyzed vocal cord, and was understandably a traumatic experience for me. And although cushioned by the love and support of my family and friends, it also instilled in me a fear that I may die. Unaware of any support systems I could access, I kept those fears to myself, afraid to upset my family by talking about it. In the following years, I did discover information about my cancer and was reassured to learn that my type, mixed papillary follicular, was highly treatable. But I wanted to make sure that no one else experienced the fear I had as a young person with cancer. So upon moving to Kingston at the age of 21, I joined the Canadian Cancer Society and became a peer support volunteer. I then joined the Thyroid Foundation of Canada in the early 90s and had the great honor and privilege of knowing our founder, Diana Abramsky, sharing in her want to help others. And then just as I started to relax about my mortality, in 1995, I learned that the cancer had spread to both of my lungs. It was only then that an endocrinologist and an oncologist became part of my healthcare team, as I had only been followed by the general surgeon previously. By now, I had a lot of questions, including why was I not given a precautionary dose of radioactive iodine following my surgery, as I had since learned that this was a common practice. I was also angry that the general surgeon did not treat me with radioactive iodine following a nuclear medical scan in 1986 that showed those same spots in my lungs, but only smaller. So now, under the care of an endocrinologist, I went on to have 3 radioactive iodine treatments, each consisting of a 4-day stay in hospital in isolation over the next 5 years. I had to put my body into a state of hypothyroidism, which we referred to as hypo hell in a chat room I belonged to, and stopped my medication 4 weeks prior to treatment. I had read that sucking on lemon drops and drinking water would help reduce the swelling of the parotid glands, but despite doing this, mine became very inflamed and sore during and after treatment. I was very nauseated from being severely hypo, and when it was time for me to go home, the nuclear medicine department brought in a Geiger counter to make sure it was safe for me to leave. It all seemed very sci-fi at the time. The treatments ablated the tumors, but left me with severe fibrosis of the lungs and a damaged parotid gland on my left side. But despite these and other health challenges, I do enjoy a full and rich life. I have traveled, have a lengthy public service career, married, and had a daughter. I do still grapple with symptoms of my disease, sometimes overwhelmingly feeling tired, cranky, or blue, but I no longer live in fear. And finding my solace came from being able to help others while advocating for my own health care. I see my endocrinologist every 6 months, at which time my blood work is completed. I am considered in remission as I do have a detectable thyroglobulin, and that is the cancer marker for thyroid cancer. And my doctor keeps my TSH very suppressed to lessen the chance of any activity. My journey has not been easy, but it has provided a wonderful filter to the world, including the importance of putting one's own misery aside to help others. And joining TFC has introduced me to many wonderful people, including fellow board members, volunteers, and patients who contact us for information. Thank you.
Thank you very much, Kim.
You're welcome.
And now I'll turn it over to Dr. Morrison for his commentary.
Well, thank you, Kim. So a lot to talk about. I guess I can just sort of go over some facts around thyroid cancer and maybe be fairly brief and leave time for questions at the end. So as you had what we would call differentiated thyroid cancer, sort of that is the thyroid cancer that originates in the main thyroid cells, the follicular cells, and the most common type is actually papillary thyroid cancer, which I guess was a component of yours, but there was a follicular component as well. So the combination is a lot more rare. There are some other types of thyroid cancer as well, which are a lot less common. More than 90% of thyroid cancers are the differentiated papillary, which makes up about 90% of those, and then some follicular. And then there are some cancers that come from those cells, but are less differentiated. So the cells have become less like thyroid. The cancer has become abnormal cells, and those are a lot different in that they can be very aggressive. It's very interesting to me that thyroid cancer can be one of the slowest growing, most indolent diseases in some cases. And then on the other extreme, fortunately, a very rare type, anaplastic, can be one of the most aggressive type of cancers that humans can get. It's quite a spectrum. There's another type of thyroid cancer that's a little bit different. There's another type of cell in the thyroid called C cells or parafollicular cells. They don't have any real known function for human beings anymore, but they're part of the calcium regulation system in some other animals, and they still exist in our thyroids, and they cause what's called medullary thyroid cancer, which is somewhat in between. It can be a little bit more aggressive than some of the differentiated thyroid cancers, but not nearly as aggressive as the poorly differentiated or anaplastic cancers. There's a huge variety of scenarios that people can go through with thyroid cancer. In some cases, removing half the thyroid is enough to cure differentiated thyroid cancer forever. And some of those people will maintain normal thyroid levels without medication afterwards. And then, somewhat towards the other extreme is Kim's story, where it can be much more difficult to treat, and there can be complications of the therapy that need to be dealt with. So I think it's important for us as doctors to understand that, everybody's situation is different. And I think in some cases, hopefully not practitioners who are treating thyroid cancer, but there is sometimes perhaps an attitude of minimizing thyroid cancer, not realizing some of the bad experiences and impact on quality of life that it can have in lots of people. Maybe I'll leave it at that for now, and of course, if there's questions at the end, we can address those.
Thank you very much, Dr. Morrison, for your comments on thyroid cancer. I think we'll now move to our second panelist, Lori Martin. Lori, can you take us through your story? She's still muted. Oh, yeah.
There.
Mhm.
Hi, my name is Lori, and I do telephone support for TFC. I was diagnosed with Hashimoto's thyroiditis in 2010 at the age of 48. This is the condensed version of my experience with thyroid disease. Looking back, I can remember in my teens having passing symptoms of exhaustion, dizziness, being itchy, and having aches and pains. Our family doctor at the time could find no reason for my symptoms. I cannot recall if I had thyroid issues with the birth of my older children. In 1987, after the birth of my last child, I had severe ear and neck pain, all over body pain, totally exhausted, dizzy, tremors, and so very cold. My family doctor informed me that I had postpartum thyroiditis. It was common and I should not worry about it. There was no follow-up. From that time, the cycle continued. Symptoms of exhaustion, headaches, joint pain, nausea, aches and pains, weight gain, balance problems, feeling like I had the flu, and then back to normal for a while. This plagued me for decades. A once straight-A student, I could barely finish college, which I attended after the birth of my children. I had moved to a different city in 1990 for college and had a different doctor who suggested that maybe I suffered from depression, which I disagreed with. Unfortunately, I had heard the words, "Nothing wrong with you," so many times that I just stopped making doctor's appointments. I had become very leery of the medical field. It was hurtful and embarrassing to have a few doctors roll their eyes when I insisted that something was not right. At that time, I had never heard about autoimmune disease or thyroid disease. My boss at the time even insisted that there was something wrong and that maybe I had undiagnosed MS because my balance was noticeably off. I moved back to my hometown in 1994. Over the years, I had mentioned to my doctor about having no periods for months or long, heavy periods, migraines, anxiety, maybe not depressed, and all the other hyper symptoms. No one ever mentioned my thyroid. In about 1998, my original family doctor did take me aside and asked if my husband and I could afford to live on one income so that I could get some rest for a while. I just went through the motions with my family and life in general. The tired that I experienced could not be described to people. My husband has always and still is the sole financial support of our family. In 2002, we moved to a small rural area. My sister, who also has thyroid disease, asked me to get my thyroid tested again, as I was really having a problem with a multitude of symptoms such as low blood pressure, dizziness, tremors, etc. My blood test came up fine. 8 years later, I thought I had a heart attack. My body stopped moving. My hands and head were shaking. I was frozen, nauseous, and the right side of my body was not working properly. Finally, I was formally diagnosed with overt hypothyroidism and Hashimotos. I started the process of adjusting to Synthroid. 3 different doctors have told me that I should have been on medication years ago. Once on Synthroid, my blood work was in range, but I was still having symptoms of exhaustion and low energy and being cold. I started having neuropathic pain in my hands and feet. I am not diabetic and all other blood work was fine. It has been mentioned to me that long-term untreated hypothyroidism could also cause this pain. I have had a handful of other blood tests and an MRI to exclude any other autoimmune diseases. I now also take other medications for neuropathic pain in my hands and feet. My free T4 is kept higher in the range, and I always keep an eye on my blood work now. Having Hashimoto's has certainly been a struggle for me. The waves of hypo symptoms have been exhausting, and my quality of life has certainly suffered over the years. I do hope in my lifetime to see changes in how thyroid disease is viewed viewed and treated. Thank you.
Thank you very much, Laurie. That was very well stated. I'd like to pass on to Dr. Morrison now for his commentary. Dr. Morrison.
Thank you, Laz, and thank you, Laurie, for that description. Sorry that you had to go through so much. So as you were saying, Hashimoto's hypothyroidism or Hashimoto's thyroiditis is really the main cause of hypothyroidism, outside of people having their thyroids removed for cancer or sometimes hyperthyroidism or other reasons. Almost everybody that has hypothyroidism when the thyroid is not working has Hashimoto's. And like you said, that's an autoimmune disease. The body makes antibodies that we talk a lot about these days, but makes antibodies that attack parts of the thyroid. And that causes inflammation in the thyroid, destruction of the tissue. Often initially with that destruction, there's swelling of the thyroid gland, but not in everybody. And then in the long run, there might be scarring and eventual shrinking of the thyroid. Postpartum thyroiditis is a part of Hashimoto's, like you alluded to, where often during pregnancy, our bodies decrease the immune response to avoid attacking the placenta and the baby. And therefore, there's not a lot of antibodies being made. And if someone is susceptible to making those antibodies, they have a risk for it. All of a sudden, after pregnancy, the immune system ramps up and might create a lot of those antibodies. And usually that could cause a hyperthyroid phase for too much thyroid hormone. But because the thyroid stores a lot of hormone, a lot of tissues make hormone as they need it. The thyroid stores thyroid hormone and releases it as it's needed. And so if there's inflammation, it can leak out. And then after that is metabolized, the levels can be low because of the damage. Fortunately, the TSH test is pretty good at diagnosing Hashimoto's if someone is, thinks to order it. The difficulty is that so many of the symptoms of hypothyroidism can be related to so many other things that can be a challenge. And unfortunately, we know that the standard of care is replacing thyroid hormone with T4 for a number of reasons, which I guess won't go into all for time's sake. But we still know that studies show that if you look at a group of people, a cohort of people who are treated for hypothyroidism and have what appears to be normal blood work, and people that have never had any thyroid problems, that on average, the scores on quality of life questionnaires can be less. The challenge is, obviously, that's not everybody. Some people have higher quality of life on one side or the other, but on average, it still affects people's life. And the challenge is we don't know what the best answer is to fix that gap. So that's somewhere where more research is definitely needed to try and help people with thyroid dysfunction. I guess I'll stop there. Again.
Thank you very much, Dr. Morrison. I think now we'll move into our third panelist, Tatiana. Do start with your story, please, Tatiana.
Thank you very much. My story, I think much like each of everyone on the call here, is slightly different and unique just to me. But I'm hoping that in sharing my story, and no matter the unique nuances, you still find a story that is relatable, empowering, and encouraging. Here's what I believe. I believe that my story will be relatable for you because I firsthand know what it's like to be hyperthyroidism or have hyperthyroidism. I also know the flip side. I know what it's like firsthand to have hypothyroidism. I also believe that my story is unique not only because of how I developed my thyroid condition, but most importantly because I've had phenomenal medical doctors from the start who have been advising me and advocating for me to do the right thing, and it was me that wasn't listening to them. Should I have listened to my medical providers from the beginning, the past 30 years of my life would have been drastically different. And because of this, I also believe that my story will be empowering and encouraging for you who has joined this webinar. Just know and be encouraged that there are amazing family doctors and endocrinologists out there. And please be empowered by knowing it is up to you to find them, and probably most important, to partner with them. You are your own health advocate and your thyroid advocate. So let me share my story with you, and it's best to start from the beginning. My name is Tatiana. I am 40 years old, and I no longer have a thyroid. A year and a half ago, I had a total thyroidectomy, which means that my whole thyroid was removed because it was deemed the best treatment for the thyroid condition that I have, a multi-nodule toxic goiter. I bet you're saying to yourself, a multi what? Because that's when I was told. I was like, a what? A toxic, a goiter, a multi? A goiter refers to an enlarged thyroid gland. Sometimes a person can have a goiter that has multiple bumps or nodules on it, and that's what makes it a multi-nodule goiter. Toxic refers to it that it makes too much thyroid hormone, so the resulting condition is hyperthyroidism. Now, how I developed hypothyroidism, well, that's the story that's different. I was born in Ukraine, and when I was 6 years old, in the early morning of April 26, 1986, a Chernobyl nuclear power plant exploded, creating what is considered to be the worst nuclear disaster in the world has ever seen. The result was a massive radiation leak that exposed most of Europe to long-term health impacts. You see, the type of radiation that was released rapidly gets ingested through air, and it localizes in your thyroid gland. Within 3 months, people were dying, getting sick, and everyone was mandated to take iodine pills. You have to remember, this is communism in Soviet Union at the time. You do what you're told and you don't know any better because there's no information available. So obviously children and youth were the most impacted. By early 2000, as many as 20,000 thyroid cases were diagnosed in patients who were, at the time of the explosion, were under 18. Me, well, for someone who never got sick before I was 6 years old, was constantly sick now. Fast forward 6 years, and I'm now 12 years old. I have 3 large bumps on my neck. I'm super skinny, super hyper. My moods are all over the place. I have insomnia. My hair is short, thin, and fragile. And the worst to me, I just could not tolerate heat. The doctors at the time were telling my parents that I need my thyroid removed. And because I have 3 nodules and each of them is pumping out thyroid hormone. But because we're immigrating to Canada in a couple of years, my parents decide that a new change of atmosphere in the new hemisphere of the world and the first world medical care would be much better for me. Therefore, we paused the removal until we reassess after a few years of us being in Canada. My thyroid is being monitored on a regular basis at this point, and the nodules stop growing. Biopsies come back inconclusive, and my thyroid levels are in range, so everything's fine. But meanwhile, I still have all the hypothyroidism symptoms that I mentioned to you before. The difference is that this has now become the norm. Me and everyone around me doesn't know a different Tatiana other than super skinny, super hyper with hair falling out. So this has become the norm. So when Canadian doctors are telling me to remove my thyroid removal, or remove it, I guess, and at this time I'm a teenager with my own voice, I vocally declined because I think I know better. Thank goodness for my doctors to stick in with me because they get me to agree to monitor, and if anything changes, we reopen this conversation. Guess what? This reopening of conversation was happening until I was 35 years old, and I can't get pregnant. At this point, I still shockingly refuse any kind of thyroid treatment. I go through fertility treatments, and I'm finally giving birth to a healthy, amazing human being at the age of 37. But here's where my story drastically changes, right, Dr. Morrison Quentin? It was a very, very difficult childbirth with many treatments and complications, and it took a huge toll on my thyroid. The nodules remained the same in size, but my thyroid levels were now through the roof to the point that my heartbeat was 140 in a calm sitting position. And this is where I finally start listening to my endocrinologist. My treatment, complete removal of the thyroid, because the area is so large, nobody can guarantee that the 15 biopsies that we have done have not ruled out cancer or anything worse. I'm at this point placed on anti-thyroid pills to lower my levels and beta blockers to lower my heartbeat, because these two have to be stabilized before my surgery. And this alone has had a very positive impact on my life. My thyroid removal surgery goes as planned. My thyroid removed, a few parathyroids because they were so embedded in my nodules, and a few lymph nodes are removed. I take daily dose of synthroid thyroid hormone every morning. And for the first month, I think this is the best thing since sliced bread. And then the hyperthyroidism hits me. And for someone who has been hyper all of my life, I literally think I'm dying at this point. I was freezing all the time. My brain is foggy. I gained a lot of weight, and my whole body just felt like melted rubber. I just couldn't move. The difference is that time is that I learned my lesson. I was no longer pretending this is normal, this is my new normal. I really then partnered with my endocrinologist to get help. I learned that it takes somewhere between 6 months to a year to stabilize your new levels, because the maturity absorption of a new dose is anywhere between 4 to 6 months. However, with the partnership of my doctor, we stabilized me in an accelerated 5 months. We had a tailored plan that was just for me. I now take 2 different doses throughout the week versus just standard 1 dose every day. I am kept slightly on the higher end to slightly mimic my previous energy levels that I've had for 40 years. And I have a very strict morning diet and afternoon supplements sort of plan. And it has been a year since it took place, and I'm a whole new balanced human being. My hair and skin completely changed. I don't have mood swings, my weight stabilized. And to me, once again, the most abnormal is that I now have a normal thermal body regulation. I know hindsight's 20/20, but I really should have listened to those doctors back in Ukraine when I was 12 years old and they were telling me to take it out, because I would have had a completely different life. And this is my message to you. If you don't feel, don't normalize that in your head. If you're not feeling heard, keep searching for the right providers, but also ask yourself, are those providers telling me what I don't want to hear? Because that was the case with me. I thought I wasn't being heard, but in reality, it wasn't me that wasn't listening. It was me that wasn't listening to my providers. I just had to partner with them for the solution that would work for me, versus at the moment, I didn't feel that that's what I needed. So because of this personal trajectory, I decided to volunteer for the Thyroid Foundation of Canada. I am now a thyroid health advocate, and I'm joining to share this story with me. This is the end of the story, and I wish you a very similar positive outcome. Feel free to ask me any questions, and I'm here to support. Thank you.
Thank you, Tatiana, for a most interesting story. Pass it over to Dr. Morrison for his comments.
Thanks, Laz, and thanks, Tatiana. A lot of ground to cover there. 35 years of story. I guess the Chernobyl incident is an interesting part of that. Unfortunately, that you were exposed to that accident. The thyroid is sort of unique in the body that it uses iodine to make thyroid hormone. The T4 and the T3 have iodine in them. That's what the 4 and the 3 are, how many iodine molecules. And I don't know the science around nuclear physics very well, but one of the problems after a nuclear power plant disaster is that radioactive iodine is in the atmosphere. And so that, as well as other types of radiation affecting health, in the short term, the radioactive iodine can affect the thyroid. And it's certainly a risk for developing a thyroid cancer down the road, and probably a risk of developing any tumors. So you had benign tumors rather than cancerous, but I suspect that probably increased the risk of that happening. I don't know whether it changed the risk of those being more functional and causing hyperthyroidism. That happened, but I don't know if that was because of the radiation or if there were other factors at play there. You point out the term toxic multinodular goiter. It's kind of a terrible term, isn't it? I don't know why the toxic is in there. Like you said, goiter just means a big thyroid, but there's seems to be negative connotations around that word as well. So maybe we should think about reworking some of the terminology. Often that can be treated with either radioactive iodine or surgery, but again, depending on the size of the thyroid and the potential risk for an undetected thyroid cancer or detected thyroid cancer, you might choose surgery. For smaller nodules where cancer may have been ruled out, then radioactive iodine is sometimes an option. Both will often result in hypothyroidism afterwards, and like you said, then dealing with a new condition. So it's getting used to something on the other end of the spectrum. I guess I will leave things there, and again, I'm happy to answer questions if that'll be helpful.
Thank you very much, Dr. Morrison. I think at this time we'll entertain some questions from the audience. So if you'd like to use your Q&A feature to enter your questions, and I'll pass it over to Catherine.
Right. Well, we have just one question to begin with. There's been some chat going on, which is great. Lots of people are making comments. So the question that I have is, I am suffering with hypothyroidism and would like to know whether it is treatable or not.
Dr. Morrison?
To unmute Dr. Morrison.
So I think I sort of alluded to earlier, hypothyroidism is treatable. Fortunately, it really is a condition that has been treatable for probably, well, centuries. Interestingly, initially people would eat animal thyroid. So that was discovered, I think Galen discovered that in ancient Greece, that it would help people that had large thyroids. They didn't know much about them, but figured that out. I should skip ahead a lot though. So for the last, I believe, 60-ish years, the main treatment for hypothyroidism has been T4, the thyroid hormone T4, and that can certainly normalize the thyroid hormone levels in a person's blood in almost all situations by taking it by mouth, unless there's some major problem with the gastrointestinal tract that may make it not absorbable, which would be, very unusual. But for the most part, that is the treatment. There is another thyroid hormone, T3, but we tend to use T4 as the first line treatment because it's easier to use. It has a much longer half-life, so the levels will stay stable. The thyroid gland makes mostly T4, and most of the T3 in our body comes from being converted from T4 at the site of action. So in the tissues, the gut, the heart, the liver, the brain, wherever the thyroid is being made, the body converts T4 to T3. Now, as I think I mentioned before, there are people that are treated with T4 and, for as far as we know, should feel well, and don't, and that's a real challenge. And I think it's often frustrating for the patient, for sure. It's frustrating for the doctor not to know what to do to help those patients that aren't feeling well. And in some cases, we do try combining T3 with the T4, and some people will think that helps. Unfortunately, the science, there just isn't good enough science to know whether that is helpful for some people or who the best people to try that in would be. That was kind of a long answer. It may have been more complicated than you were looking for.
Thank you very much, Dr. Morrison. Next question.
Right. Yes, question from Jill and John. What is the reason for keeping Kim's TSH suppressed?
Dr. Morrison?
Yeah.
Oh, sorry, Kim, do you want to
Well,
talk to that?
my understanding, Dr. Morrison, is that keeping it suppressed doesn't allow any cancer cells to become more active. So I think I'm kept more suppressed than a normal person would under thyroid medication. That's my understanding.
Yeah, I think that's right. Again, I'm not your doctor, so I'm not making
No.
those kind of decisions and don't know all the details. But in general, with thyroid cancer, the differentiated types, um, we know thyroid stimulating hormone, TSH, comes from the pituitary gland in the brain. It tells the thyroid to make more thyroid hormone, tells the doctor if they do the blood test to give more or less thyroid hormone, depending on which end it's on. But the other thing it can do is stimulate thyroid tissue to grow. So normal thyroid tissue. That's one of the reasons people with hypothyroidism before it's diagnosed can have a large thyroid, is that TSH goes up and makes the thyroid tissue grow, even though it's not working very well to make the thyroid hormone. And so it can also make differentiated thyroid cancers grow. So certainly in people who there may be some low burden of residual thyroid cancer after treatment, keeping that very low is important. On the other end of the spectrum, people who seem to be completely cured of their thyroid cancer, we tend not to suppress those people's TSH anymore, because the potential harms from too much thyroid hormone would outweigh really a lack of benefit. If there's no thyroid tissue thought to be, thyroid cancer tissue thought to be present, it's not going to make it grow.
Thank you. Next question. Oh, you're muted.
Sorry. From Mary, who wants to know, is it normal to not feel the cold much when you have Hashimoto's?
Sorry, was that to not feel cold?
To not feel the cold much when you have Hashimoto's?
Well, everybody is certainly different. You know, a lot of people with hypothyroidism diagnosed on their blood work, it's pretty clear they have the condition. Sometimes people will not have symptoms when they're diagnosed with that. Some people with milder disease, it'll affect the way they feel a lot more. Some people will have some of the symptoms and not others. It's really difficult to predict how anybody will feel based on the blood tests. I mean, the worse the hypothyroidism is, the more likely that you have some of those symptoms, but it is amazingly variable about how some patients will have some symptoms and some patients will have others, and some people will feel one way with blood tests that look a certain way, and another person with the same blood test might feel very different. So it can be completely variable. You certainly can't say, because I don't feel cold, I can't have Hashimoto's. That would not necessarily be the case.
Thank you.
Okay, we've got a lot of questions now. So this is a question. I have taken desiccated thyroid for about a year after having taken Synthroid for about 10 years. My thyroid levels fluctuate. What are your opinions on desiccated thyroid? I have other questions which I'll ask after you answer this. We're only allowing one question per person at this time. So, okay, Dr. Morrison.
Thanks. Maybe some other people have the same questions. So, as far as desiccated thyroid hormone, again, as I said before, our first line standard treatment is the T4 for the reasons I mentioned. But also there is this problem where some people don't feel well on that treatment, and in that case, I am as a doctor for people who are interested in trying different combinations of thyroid hormone, I will help facilitate that in a way that seems to be safe. And my main goal as the doctor would be to keep the TSH in the normal range. As you know, as the best of our knowledge, that would mean that the thyroid hormone levels are likely safe. It's you know, impossible really to say 100% for sure what types of thyroid hormone replacement strategies are safe without, large studies following people on different regimens for many years. But again, it makes sense that if the TSH is within the normal range, then your body's happy with your amount of thyroid hormone. That should be safe. People will want to use a combination of T4 and T3 separately. I tend to favor that approach first, unless the patient has an opinion about wanting to try a different way. And the reason for that is that it's easier to control both parts of the dose. You give a certain amount of T4 and a certain amount of T3. And you can do that in a way that mimics the way that a human thyroid would normally make those hormones, or have the concentrations in the blood similar to what they would be in somebody with a working thyroid. And also, you can take the T3 at multiple times a day. I said one of the advantages of T4 is the longer action, longer half-life. And so for T3, it's probably better to take that divided up into 2 or 3 doses rather than all in one big dose. Some people will prefer desiccated thyroid hormone, or have tried it and feel better on it. I do suggest, usually if someone's taking desiccated, that it would be ideal to take that in more than 1 dose per day. So divide it up and take half, in the morning, half in the evening or something. Although that can sometimes be difficult because there are not as many different dosage forms available. Desiccated thyroid hormone contains both T4 and T3. It is basically dry animal thyroid. And one of the challenges with it is that it usually comes from pigs, and in pigs, the amount of T4 to T3 in the blood concentrations are different than humans. In humans, it's about 15 to 1, T4 to T3, and in pigs, it's about 4 to 1. So when you take desiccated, it can sometimes be a bit difficult to regulate the T4 and T3 balance. But again, if someone feels well and their TSH is normal, probably there's not a risk to health in whatever they're taking for thyroid hormone.
Thank you, Dr. Morrison. Next question.
Next question from Pat. I have Hashimoto's. I was wondering if there's any information on this disease and the COVID-19 vaccine.
I don't know anything specific, but I don't think there's any reason to have a concern. Certainly, although some immune deficient conditions, or people who have problems with decreased immunity and that they're at higher risk of infections, there may be concerns about taking the vaccine. An autoimmune disease like Hashimoto's would not be something that decreases the potential immune response, either the response to the vaccine or the risks of taking the vaccine. So I don't think there's any difference for somebody in considering the COVID vaccination because of Hashimoto's.
Thank you, Dr. Morrison.
So next question. Excuse me. When I've done any kind of exercise, my body hurts, and this could last for days. Is this normal? And if it is, what can be done to help eliminate the post-exercise pain?
So it could be normal. It depends. Certainly high intensity exercise can cause some mild muscle damage and elevate the muscle enzymes in the blood. If someone was had untreated hypothyroidism, then that risk would be worse. So sometimes the muscle enzymes in the blood can be high if measured in someone who has significant untreated hypothyroidism. Once the hypothyroidism is treated and the TSH and thyroid hormones are in the normal range, then the background Hashimoto's should not cause either the muscle enzymes to be high or there to be a significant difference in muscle enzymes or soreness after exercise. In general, for people without any type of thyroid disease, get sore after exercise, just working on the intensity, sort of building up more gradually, I think. If one's hypothyroid, then addressing that and getting those levels normal before doing intensive exercise might be recommended.
Thank you.
This is a question from Donna. Dr. Morrison, many members of my family have been diagnosed with hypothyroidism, but none of them have been diagnosed with Hashimoto's. We've always assumed it must have a genetic link. I'm surprised to hear you say that almost everyone with hypothyroidism has Hashimoto's. Is there not a kind of hypothyroidism that is genetic? Should everyone with hypothyroidism who hasn't had their gland removed be tested for Hashimoto's?
So often hypothyroidism is assumed to be Hashimoto's, and not all doctors who diagnose it necessarily would, use the term. It's not recommended to do confirmatory testing for Hashimoto's because it is by far and away so much the most common. There is a genetic connection. So I don't know for sure, but I would suspect that your family probably has Hashimoto's hypothyroidism, and that the term Hashimoto's just hasn't been used much. Like some other autoimmune diseases, it is much more common if you have family members with the condition to develop it yourself. So again, unless there's a much less common problem with the pituitary gland, or if you've had your thyroid removed, those can also cause hypothyroidism, but it's just so much more common to be Hashimoto's that we often assume that. Not everybody necessarily uses the word. There are tests you can do to confirm it, but it doesn't add anything to the treatment. You might wonder, well, why not get rid of the antibodies, right? I mean, that's an excellent question. The problem is that anything that we could do to our immune system that would get rid of the antibodies that cause hypothyroidism would cause much more significant side effects and problems. Whereas, we're able to replace the hormones that the thyroid make without causing such significant side effects.
Thank you. Next question, Catherine. Unmute.
Oh, you're muted.
Sorry. Are there other things that can help with hypothyroid disease? For instance, diet, exercise, etc.
I think as far as we know, maybe not directly. Certainly, overall health will probably help a lot of the symptoms that hypothyroidism could make worse. Energy levels, weight changes, things like that. So trying to be healthy in other aspects of life, I think, will likely help people feel better. As far as preventing the antibodies from developing or preventing the hypothyroidism from progressing and getting worse, I think as far as we know, there are not sort of health or diet or lifestyle changes that a person can do to try and fix that.
Thank you.
Okay.
Why? Couple more.
Sorry?
We'll take a couple more, yeah.
Okay. This person wants to know why doctors in Canada do not prescribe more often a combination of erythrithyroid and cytomel for Hashimoto hypothyroidism, especially for people who do not convert well T4 into T3 because of genetic predisposition. predisposition. In general, my experience with doctors is that they don't know how to fine tune doses so patients can feel completely free of symptoms.
That's a great question, and I think that comes back to the problem that we can't resolve based on the level of evidence we have for treating hypothyroidism right now. I struggle with trying to help people who are having symptoms and are treated for hypothyroidism, and I'm open to prescribing other combinations. But I can't tell someone that this is what I'm gonna give you this much T3 or this much desiccated, and that's gonna make you feel better, because I don't know. I have patients where we'll try a combination of T4 and T3, and they feel much better and stay on that for years and are happy. I have other patients where we try that and they don't feel any different, and they go back to the T4. And whereas it's excellent questions about trying to identify people that don't convert T4 to T3 as well, there is science that suggests there could be problems with that in some people, but there isn't easily available testing to figure that out, and there's no evidence that there's a correlation between a certain T4 and T3 level that can be used to suggest a certain treatment to fix, right? So somebody might have what looks like a lower T3 level and feel fine. Somebody else might have a higher T3 level and not feel well, and they might feel better on the combination. So at this point, we're kind of stuck with a little bit of a trial and error. Those probably better scientific answers to the question are not really available, and so I'll try and help people find what works for them. But I can't look at a set of test results and say, okay, now this is what you need here, and this is what you need for T3, and that'll fix it.
Okay, can we take one more, Catherine?
All right, this one is from Anne. What should the optimal level be for the normal range? I'm diagnosed hypothyroid and have been on medication for close to 17 years. Problem is that whenever my T4 levels are tested, they always register right on the border of the low end of the normal range. The dose is 118 milligrams, I'm not sure I didn't say that right, daily. I still have some symptoms, mild to moderate. I gained 47 pounds and cannot lose the weight. I'm postmenopausal and have to eat an unsustainable 1,200 calories per day. What would be the recommended dosage?
These are tough questions. And yeah, obviously I can't give specific medical advice for anybody's specific medical condition. These are tough questions. Nobody knows the answers to some of these. As far as the optimal range for TSH, I'm not sure that we know that. If you think about it, approximately 0.5 to 5.0 is what labs will report as around normal, and that's 10 times different. So some people have 10 times more TSH than others. That's a huge difference. Most other things that we test in the body don't vary that much at all. I mean, if you think about blood counts, that would be crazy that 10 times as many red blood cells would be considered normal compared to somebody else. But that's how humans are. That's what our TSH levels are. Those are developed by testing a bunch of people without thyroid disease and averaging the levels. So it's tough, and I think generally speaking, we try to aim for the lower half of the normal range for TSH, thinking that's probably optimal without it being below normal. But again, it's hard to know. We don't know that people should have a TSH similar to what it was when they were healthy. We don't always know what someone's TSH was before they were healthy, and we don't know whether there was already some impact from Hashimoto's on those supposedly normal TSH levels before someone is diagnosed with hypothyroidism. So it's a tough question. The easy answer is sort of trying to keep the TSH within the lower half of the normal range. But you know, that's maybe not a good enough answer for everybody.
Thank you very much, Dr. Morrison. I think this ends the Q&A part session of our webinar. I know we have some, thank you. I know we have some questions that are still outstanding. I don't know if we can track these and send them to the people that have requested. Yes. So we'll try and do that. We'll review them. We do get quite a few questions, and we have to really be careful how many we pass on to Dr. Morrison. We don't want him to be inundated with you know, hundreds of questions from us. So we try and respect that a little bit. So I would like to thank Dr. Morrison. Thank you very much for being our guest speaker. We appreciate it very much. And also our panelists. Stories were really interesting. And I think it's good to have a little bit of variety. It was a good test for us. This is really a pilot for us. So we want to see how it went and how well we managed it, so that we can plan for additional ones next year. So we'll try and come up with some interesting stories as well. And we'll have different guest speakers. So we'll carry on next year. So I want to again thank everyone and Catherine for all her help. I hope you have a terrific rest of the day. Thank you. Bye.
Thank you. Bye.
Bye.